First of all, I want to point out a difference between Koch and myself. He pretended to be confused. I'm definitely confused. So I will share my confusion with you, starting with this, because I'm still puzzled of something that we have built ourselves. We have never had this problem with nuke use in HBV. We had good reasons. I mean, they are a lifelong treatment, so obviously we had to go on. We know that the first available drugs without interferon were PIs, and we don't like using them in decompensated patients. So we decided that we had to divide the world in before and after transplant. And now that we have nukes, which are basically the same drugs, they need the same phosphorylation within the liver, we have never learned how to use it across transplant, or like in my country for a long time, was actually forbidden to do that. So this left me a little bit puzzled, because we are stuck with this decision: which should we treat before, are we treating after? It's like the story who came first between the egg and the chicken, which is a strange story. Somebody has solved the issue, of course. So let's see which is the outline. I'll go through the same study that Xavier has shown you, trying to see which is the clinical result, and Nora has already showed something about that. Now, and the second question is, which is the impact on the listing of the patient, on the function of the liver, and then who we should treat and not treat, and how we should do it. I won't go through the last point. Before going into the studies, I think this is a proof of concept study which is very interesting. Of course, we know that we see a combination which is no longer what we are using, and it's not exactly what we expect. But the proof of concept is interesting, because this study, we have an initial measurement of portal pressure, then we have a control group, and again a measure of portal pressure, then the treated group have been measured at the end, and then there is a crossover group with the measurement. So we have a control group, and we see which is the clinical behavior of portal pressure, and it's interesting to see that there is a natural variation in those patients, which has been followed before and after a period, and this variation is never greater than 20%. But when we move and see the treated patient, of course, we see a similar variation, but there is a small number of patients which actually get a better results in terms of recompensation of the disease, and not surprisingly, this happens mostly in patients with a MEL lower than 10. So the one who gets to an HVPG less than 12, the only one basically are patients which are really very good patients and well compensated. So portal hypertension is actually the leading factor in deciding what is going on from the clinical standpoint in this patient. And we know that we can have several issues: cell-to-cell transmission, we can have exposure to the drug within the liver, diversion of the liver flux. So there are a number of reasons why an advanced disease can deliver such results. So let's see which is the impact of pre-transplant on recurrence. And we have to say that we have just one study, which is definitely not representative of most of the patients that we are dealing with, because this is only on HCC patients. They were treated with a suboptimal treatment, but the proof of concept stays there. If you treat the patient and make them negative for at least 28 days before transplanting them, you basically prevent recurrence. So it's a proof of concept which is going to hold for any of the combination. But these were very compensated patients, and they were bound to go to transplant, all those patients. So there was no delisting option. And this is the only study we are referring to. So when we discuss about the issue of suppressing for 30 days, we need to remember that it is mostly related to just one study. I don't totally agree with the idea that we should inactivate the patient. If somebody has an acute and chronic event, my personal opinion is that that patient should go for transplant and go on a cross-transplant treatment rather than halting the transplant. And of course, we should remember that this is the single study. So which is the impact? This is the number of studies dealing with cirrhotic patient, mostly decompensated child B or C. And as you can see, we have a reasonably good SVR. And as you can see, these numbers, more or less, will repeat in every study. What is more important, and I think Noah clearly pointed out, this lower SVR is not just relapse or breakthrough or non-response. This is death competing with this. So I think we need to keep in mind this. We are treating child C patient, and the life expectancy of those patients is bound to give these kind of results. And of course, as an average of all these studies, we have 1/3 of the patient which has an increase of a median 2 points MELD. So this median means nothing, because 2 points is nothing, it's not going to change anything. But as you can see, you have patient changing nothing or patient changing a lot. And we are not able to predict which they are. And of course, there is an increase in condition, and I'm still wondering what is the real reason why we still see this. I don't think it's related to the treatment. I don't think it's related to the drug. I think it's related to the condition of those patients, because most of them, they are bound to die anyhow. And so this will be very quick, a very quick view of the clinical results. We will always see this 15 to 20% of patients, according to any treatment, this is the SOLAR one, which will not improve, which will keep on having a problem, and we will see in the SOLAR 2 studies, and this can happen in patients with an SVR and also in patients without an SVR, so there is a mix of combination. One interesting point is in most studies, you will see that the child C patient, in the long term, will actually have less events in terms of numbers, reduction or increase in MELD. And it's quite obvious that if you are a child C patient, advanced child C patient, the worsening condition for you is death, not increasing your child. So we need to keep this in mind. Same thing for the Ali-1 study. As you can see, either child PUG or child C, we will see the same split results. So we are not able to predict who is going to do better and which are the patients which are going worse. We need to look into cofactors. None of the studies have specifically looked into the role of cofactors. None of us believe that those patients have only HCV as a problem, of course, and we need to monitor this very carefully. And again, if you pull all the data together, you can see that you have a change, a mean change of MELD, which is negligible. It's 0.85. As a mean means nothing. What is interesting is that here, the clearer bars are the relapsing patient, and you have both relapsing patient and failure on both sides. So you have patients that still, even if they relapse, they end up with a better MELD or a better child than they were before. But also patients which are responding fine are actually getting worse. The same thing we are always saying. And of course, in the untreated patient, which was the group, this part is much more represented. It's interesting that we see this. And it is absolutely consistent with the study on portal hypertension, which is actually having fluctuation, and we have no idea on which were the treatment, let's say beta blockers or any other treatment. So we have other means of controlling this disease, which is not curing, it's just trying to control it, and so this does have an impact. This study actually showed clearly something which is not that relevant from the clinical standpoint, because I don't think it's surprising that if your albumin is over 35, you're going to do well. I mean, you're selecting good patients. The point is, how bad should be your albumin? Is it like they pointed out 2.8 level? Is it different? Age is a factor, and Noah pointed out before. And of course, the older you are, the longer is presumed to be the disease, the longer the derangement of the communication within the liver, so it's reasonable. And of course, sodium is a very relevant issue in terms of liver disease. We modified MELD including sodium, so it tells everything. So if you have a bad sodium, it means that you are on diuretics, your portal hypertension is difficult to control, and you should not expect great results from eradicating the virus itself. This is the SALT study, small number of patients, just 30 with child B. We don't care about the result, we have seen them. But as you can see, it's every time the same picture of patient, which the most interesting are the ones that are actually caring less of being treated. They stay exactly like they were before, which is interesting. And the same thing for the MELD score, as you can see. So it's quite boring, not like Xavier was saying, which is a funny presentation. Astral 4, it's interesting because we are using probably a better combination, and we start seeing a little bit less worsening at the end of this group. There is the 24 weeks, which I think it's important in selecting as time, because we have said before that 12 weeks may be not enough to evaluate what is happening to this patient. You know, the population that was on the 24 weeks and then they had the 12 more weeks of observation, we may end up finding something more interesting. And this is in child PUG, and this is in the MELD. And again, as you can see, it's interesting, as what I said before, if your MELD is greater than 15, it looks like it's much better than being a MELD less than 15. I don't think it's true, of course. We need to get into the detail and see how many of these patients were actually above 20. And as far as I could get from the paper is most of them. So this is a selected group that probably there is no way that we are changing the natural history. Impact study, we have seen before, the criteria are known to everybody, the results in terms of SVR, we know them, but again, we see something interesting, because if you see this group of patients getting worse, you have patients with less than 10, you have patients with 10 to 15, or as expected, greater to 15. So everybody gets into this final risk of worsening. So we need to find which are the factors that can help us in identifying this patient, and I think we are not that close. And this is what has just been said. I just chose this, but we can use any of the other studies. It looks like there is a point of no return for all the, it's maybe MELD of 20 is a surrogate marker of portal hypertension at a level in which we are not restoring function, even clearing the virus. So we still don't know, and I definitely don't know myself. Is 20 is a good number, or it is a different one? Can we delist patient with these results? There are a couple of studies that I can show you, and actually I will show you just one study, because the European study, Christophe is going to show you the result. This is the French paper. They just selected to analyze a group of patients listed for transplantation with an interferon-free combination, 18 French centers. The inclusion criteria, they were transplanted with or without hepatocellular carcinoma, treated with DAAs. Of course, there was a difference in MELD at baseline and at listing between the compensated and HCC, which is absolutely as expected. And we have seen this before. Most of the improvement were for child A patients, but a reasonable part of child B and child C, they actually did improve. And the bottom line is that 16% of those patients were actually delisted as a result of improvement, which is a number, and we will see the data that Christophe will present. It's quite strong in a follow-up of about 68 weeks. Who should be treated or not, given these results? I want to give you my unwise prediction. Somebody much more knowledgeable than me that usually said, I will never make prediction about future especially. But if we have waitlisted patients, we need to decide which is our target. We need to see if we have chances, real chances of delisting, and which is the action that we should take. If you have an HCC patient, your first target is no recurrence. Then if you achieve SVR, it's okay. You may actually improve the capability of treating, bridging this patient in treatment, but you don't have really delisting chances as a result of SVR, and we need to treat those patients. If you have the so-called low MELD patients, maybe in our country they are the patient with the exception to transplantation, then your aim in those patients should be SVR, and we have no idea if we can push the delisting up to this number in that specific population, but of course we need to treat all of them. Let's call them high-MELD patient. We are aiming for no recurrence if we want to treat them. We hardly can aim for SVR in this category of patient, and I put a question mark because I really don't know if 20 is okay, it is too low, or it is too high. But I wouldn't expect that much, that 10–15% maximum. And of course, you have to treat them as a recommendation according to the local epidemiology, because if your MELD at transplant, the average MELD is 35 or 40, it's difficult that this patient is going to have a real benefit in terms of prevention. And of course, in the very high MELD, and again, I put a question mark because I really don't know if the very high MELD is over 25 or just the point of no return of 20, and I don't think we have the numbers, but we all have the clinical impression that it's only episodical, the chance of delisting such a patient. And then you have to consider treating those patients, and probably a preemptive approach may be an idea, and if in the last section we'll have time, we'll show a very small experience on what could be an approach in this patient. Of course, we need to remember that in those patients with a large MELD improvement, you may hamper their chance to get a transplant in time. So there are some pros and some cons. Of course, if you want to treat a patient which is waitlisted, you can expect improvement in liver function. You have a chance of avoiding transplanting some patient, but we still need to identify the gray area that Noah pointed out. It's easy to handle the very sick and the not sick at all patient. It's complicated to treat the in-between patient. And of course, if we can avoid transplant in some patient, the organ pool can benefit of this. We can definitely prevent post-transplant recurrence, but we need to remember that this may be the only option for cure in a patient that for one reason or the other is not a transplant candidate. Which are the cons? Well, this may hamper your opportunity for a curative treatment. And we have seen this with Hep B. We have been treating Hep B. We have seen patients recompensating, then developing hepatocellular carcinoma beyond Milan criteria and losing their chance of transplantation. Or we have seen patients clearing Hep V, being delisted at 68 or 69 years old and decompensate or develop HCC at 74, 75, and maybe out of at least transplanted. So we need to remember that this might be a practical problem. We have a sort of an ethical preclusion from using an HCV positive organ for a patient who has been cured for HCV. It's an issue. We need to remember that we have no idea which is the residual risk of decompensation of those patients. They might have cofactors. We need to learn how to measure and how to validate the portal pressure on those patients to predict who is going to have a chance of decompensation. And we have just discussed the issue of HCC, which is still something that needs to be looked into. And of course, in case of DAA failure before transplantation because of a suboptimal treatment, we need to assess the risk of how to manage those patients post-transplantation. And with this, I thank you for your attention.